Okay. A 26, sorry, a 67-year-old woman comes to the physician because of excessive sleepiness and fatigue. She has required more sleep for several years, but the problem became increasingly worse during the past 7 months. Sometimes she falls asleep in the middle of the conversation at dinner. She recently collapsed on the floor of her apartment. She was aware of surroundings but unable to move for 5 minutes. She has no history of seizures. Um, Her only medication is celecoxib for osteoarthritis. He appears to be well nourished. Physical examination shows limited range of motion in her lower extremity. There is painful swelling and crepitus of her knees. There is mild, she has moderate pain on standing. And ECG, EEG 72-hour ambulatory ECG monitoring shows no abnormality. Polysomnography is pending. Mm, Which of the following is the most appropriate pharmacotherapy?
Ready?
Yes.
It's methylphenidate. Phenidate is non-amphetamine CNS stimulant medication that is used in the treatment of narcolepsy, which is the most likely diagnosis in this patient with fatigue and episodes of cataplexy. Methylphenidate works by blocking reuptake of norepinephrine and dopamine in the presynaptic neurons. Pathogenesis of narcolepsy involves loss of orexin and orexin, which are neurotransmitters found primarily in the hypothalamus that promote wakefulness and rapid eye movement, REM sleep. That promote wakefulness and inhibit REM sleep. Loss of these neurotransmitter permits abnormal transitions from wakefulness to REM sleep with subsequent development of hallucination and other features of narcolepsy, including cataplexy and sleep paralysis. Diagnosis can be made in patients with daytime somnolence and cataplexy or in cases where cataplexy is not present with sleep latency testing. Polysomnography is appropriate to support the diagnosis and rule out similar sleep-related conditions such as sleep apnea. Occasionally, patients undergo lumbar puncture to directly measure concentrations of orexin in the CSF, but is generally not required for the diagnosis. Pharmacotherapy is directed at promoting wakefulness, and methylphenidate is one relative safe and effective stimulant. It's not mirtazapine antidepressant that increases presynaptic release of serotonin or epinephrine. It tends to cause drowsiness and weight gain, and it's occasionally used for depression. TCA, oh, nortriptyline TCA that is used to treat MDD and is used off label for a number of conditions such as chronic pain, postherpetic neuralgia, and diabetic neuropathy. It can cause drowsiness. It is not a trazodone, inhibits reuptake of serotonin, and is also a potent histamine blocker. It's used to treat depression, but also causes drowsiness. Um, so it's so it's used of label to treat insomnia. Okay, next.
Okay. Can you tell me the diagnostic criteria of narcolepsy?
Mm, I need to know there was a diagnostic criteria.
Okay. According to DSM-5 diagnostic criteria of the narcolepsy, recurrent lapses into sleep or naps, Recurrent lapses into sleep or naps more than 3 times a week for more than 3 months, and one or more than one of the following, like cataplexy, low CSF fluid levels of hypocretin 1, and shortened REM sleep latency.
Mhm.
Okay,
Okay.
and there
Okay.
may be associated feature like hypnagogic and hypnopompic paralysis.
Mm-hmm.
Okay,
Okay. Thank
and
you.
the drug of choice, modafinil. Modafinil is the first line treatment for narcolepsy, and we can give dextroamphetamine and methylphenidate.
Mm-hmm.
Okay,
Thank you.
a 72-year-old right-handed woman is brought to the emergency department 30 minutes after onset of double vision. 30 minutes after onset of double vision and right-sided weakness that began while she was eating breakfast. She has type 2 diabetes mellitus and hypertension. Medication include glyburide and atenolol. Her temperature is 37 degrees Celsius, pulse is 80 per minute regular, blood pressure is 170 by 105. He is alert oriented and her speech is fluent but mildly slurred. She can follow complex commands. She can follow complex commands. Cranial nerve examination show left ptosis. Cranial nerve examination show left ptosis. Adduction and elevation of the left eye. Adduction and elevation of the left eye are impaired. Ocular movements are full on the right. The right pupil is 3 centimeter, left pupil is 5 millimeter. The right pupil reacts normally, but the left pupil does not constrict either on direct or consensual right reflex. Deep tendon reflex are 3 plus on the right and the 2 plus on the left. Babinski sign is present on the right and absent on the left. There is no ataxia sensation is intact. Which of the following is the most likely location of this patient lesion? Yes,
So it's the left midbrain. This patient likely has a lesion of the left midbrain that affects the cerebral peduncle and the oculomotor nerve, which causes contralateral hemiparesis and ipsilateral oculomotor palsy known as Weber syndrome. Cerebral peduncle refers to the anterior portion of the midbrain. Um, yeah, it includes the cross cerebri, which contain the corticospinal tract and is supplied by paramedian branches of the posterior cerebral artery. Brainstem lesion of the corticospinal tract leads to contralateral weakness in an upper motor neuron pattern and dysfunction, spastic paralysis, Babinski sign of perfection. The corticobulbar tract located within the cerebral conductor may also be affected in Weber syndrome, leading to facial droop and weakness. The oculomotor nerve, cranial nerve 3, is located anteriorly between the two cerebral peduncles and may be affected by strokes of the paramedian branches of the PCA, leading to ipsilateral dysfunction of the extraocular muscles and consequent diplopia, ptosis, and primary gaze palsy. Cerebral infarctions or strokes occur as a result of ischemic or hemorrhagic loss loss of blood supply to the midbrain. Risk factors of stroke include smoking, hypertension, diabetes, carotid intracranial atherosclerotic disease, history of hypercoagulability, AFib, and advanced age. Classically, stroke manifests as neurologic deficit related to the affected part of the brain. It is not lesion to the left cerebral cortex, may cause contralateral hemiparesis of the upper and lower extremities, and facial weakness. However, oculomotor palsy would be atypical. And lesions to the internal capsule occur in a lacunar infarct. The internal capsule primarily contains the descending corticospinal tract, though it also contains axons of additional pathways, including third or the sensory neurons. Internal capsule lacunar infarct can present with purely motor deficit that cause contralateral hemiparesis, ataxic hemiparesis, and clump hand dysarthria. Okay, next.
Over the past 3 months, a 40-year-old over the past 3 months, a 40-year-old woman has had multiple 1 to 2 minutes episodes of numbness and tingling that begin in the right hand, then spread to the right arm and face. A neurologic examination shows normal finding. The most likely cause is a lesion. Which of the following set? Right hand, then spread to the right arm and face.
Ready?
Yes,
Yeah, ready? Sorry,
yes,
I hear you. Okay. So it's the parietal lobe, focal neurologic deficit that start in one area of the body and spread as suggestive of partial seizure activity. Without an alteration in level of consciousness, this will be defined as simple partial seizure manifesting with sensory symptoms, also called a simple partial somatosensory symptom, somatosensory seizures. This type of seizure is most commonly associated with lesions of the parietal lobe as a result of the involvement of the primary somatosensory cortex, which processes sensory input from the contralateral side of the body. Patients typically present with numbness, tingling, warm and or pain, often manifestation of parietal lobe epileptic activity may include receptive aphasia, dyslexia, and other language comprehension disturbances um, because of involvement of Wernicke area at the junction of the partial and temporal lobes. And it's not medulla. Brainstem lesion involving the medulla, midbrain, and pons may result in focal seizure activity characterized by convulsive movements. However, brainstem involvement more typically occurs with generalized tonic-clonic seizures. Mm.
so what is the summary in this question?
That the parietal lobe causes partial seizure. Partial seizure.
Okay. Is there any specific location for seizure disorder, like this parietal lobe can cause partial seizure? You
I don't
got
know.
my point.
I don't. No, no,
Like, is there uh, there is partial seizure, there is complex seizure, there is status epilepticus. So, is there
hmm
any specific area where, like, status epilepticus involves this area, and focal seizure, like this question, focal neurological deficit in partial seizure, it involves
no.
the
I think I get what you're saying, but no, I never met like a table like that that says, oh, all epileptic seizures or complex seizures starts here, or all partial seizures. I never had a table like that. I
yes.
know that usually seizures is the temporal lobe. Um, that's usually what I know. Um, but I think the question here was trying to is it was to try to say that yeah, usually seizures are temporal lobe, but partial seizures, I guess they can also start in the parietal lobe.
Parietal lobe.
Yeah, but I never seen a table that like characterizes it like that. Like where does the seizure start depending on the type of seizure? I haven't seen a table like that.
Okay. Okay, can you give me a minute? I have an important call.
Yes.
Okay.
Yes.
Okay.
Okay, ready.
A 72-year-old man comes to the physician because of 3-month history of increasingly depressed mood, fatigue, difficulty concentrating, and a decreased appetite resulting in 2.3 kg weight loss. He was diagnosed with Parkinson's disease 2 years ago. He also had hypertension, BPH. His medications are amlodipine, carbidopa, and tamsulosin. He has smoked one and 1.5 pack of cigarettes daily for 47 years. He states that he would like to stop smoking. Vital signs are within normal limit. Physical examination shows mild cogwheel rigidity, resting tremor of the hand, and the gait instability. Mental status examination mental status examination has a depressed mood and forlorn effect. Re- Results of the lab studies include thyroid function test within the reference or range. Additional of which of the following is the most appropriate next step in the pharmacotherapy?
Ready.
Is it depressive disorder, Parkinson?
What do you mean? I don't understand.
Okay,
Ready?
yes.
So it's bupropion can be used patients with Parkinson, MDD, and nicotine use disorder to treat depression and promote abstinence to nicotine. Depression is a common complication of Parkinson's. Since this patient depression began after his Parkinson's disease diagnosis, his depression is likely a result of Parkinson's disease and should be diagnosed as MDD caused by another medical condition. Many patients with this diagnosis improve after the medical condition resolves. Since Parkinson's disease does not remit, the depression should be treated pharmacologically. SSRIs are first-line medications for patients with MDD and are frequently used for patients with comorbid Parkinson and MDD disorder because of the yeah. However, serotonergic medication are not effective for smoking cessation. Bupropion is antidepressant medication that increases the reuptake of dopamine and norepinephrine, which targets depressive symptoms and antagonizes the nicotine acetylcholine receptor, which targets tobacco. Um, Bupropion can increase blood pressure, so this patient with a history of hypertension will have his blood pressure monitored. It is not mirtazapine. Where was it?
I don't understand
Right
the
here.
explanation.
Uh,
Why it is bupropion?
uh, Bupropion is, bupropion is antidepressant,
Yes.
right? So
And
this guy has an,
Yes, Parkinson patient can have depression. Okay,
yeah,
that I have understood. Then,
this patient has depression, MDD, and he wants to quit smoking. So you're trying to give him a drug that's going to help with his
okay.
depression and that's going to help with his quit smoking.
Depression plus smoking. So that's why bupropion.
That's why bupropion. Yeah.
And if it is only depression, then SSRI.
And then yeah, you can give SSRI. Yeah. Citalopram is a SSRI, duloxetine is a SNRI, and mirtazapine is a selective alpha 2 receptor antagonist and serotonin modulator. All these medication can be utilized for MDD or depressive in this case. However, none of these medications are effective for smoking cessation. Now you get it?
Yes.
Okay, perfect. Next.
Okay. Next. A 72-year-old woman is brought to the physician by her husband because of visual hallucination. During the first 2 weeks, visual hallucination during the first 2 weeks, she has a 10-year history of hypertension, 5-year 10-year history of hypertension, 5-year history of Parkinson's disease. Current medication include hydrochlorothiazide, aspirin, metoprolol, carbidopa, levodopa. 3 weeks ago, her carbidopa levodopa dose was increased because of decreased mobility, and metoprolol was added to her medication regimen because of inadequate blood pressure control. She smoked one pack of cigarettes 40 years but quit 10 years ago. She drinks one glass of wine with dinner every night. Her temperature is 36.8, pulse 58 per minute, respiration 18 per minute, blood pressure 148 over 80 millimeter of mercury. Pulse oximetry on room air show oxygen saturation 92%. Neurologic examination shows a restrained tremor of the hands. The cogwheel, rigidity, deep tendon reflex are absent at the ankles. Her gait is shuffling. Mental status shows Mental status shows a constricted effect. She is oriented to person but not the place and the time. She can recall one of the three objects after 5 minutes. She says she sees ghost-like figures entering into the room. Results of lab are within reference range. A CT scan of the head show mild atrophy. Which of the following is the most likely cause of this patient's visual hallucination?
Ready?
Yes,
So is adverse effect of carbidopa levodopa. Adverse effect of carbidopa levodopa is the most likely cause of this patient visual hallucination. Parkinson is a progressive neurologic disease that manifests as bradycardia of bradykinesia, rigidity, mass phases, and rest impairment. It's secondary to obstruction of dopamine producing neurons in the substantia nigra. So pharmacologic focuses on replacing dopamine with carbidopa levodopa. Frequently in early disease course, treatment is effective, but over time many patients experience on and off phenomenon where treatment only works for a short time after each dose before the effects dissipate. This often promotes an increase in dose of carbidopa-levodopa or a change in the dosing interval. But in elderly patients, this can result in multiple off-target effects, adverse effects, including hallucination. This patient has no evidence of another underlying medical illness that may cause the hallucinations. So the next step should be to lower the dose of carbidopa to resolve the hallucination. Patients who are intolerant or refractory to pharmacotherapy should be considered for deep brain stimulation. And it's not the progression of Parkinson is a possibility in this patient as evidenced by her worsening bradykinesia. But this is less likely to be the cause of her hallucinations than the time correlated effect of increasing the dose of medication with non hallucinogenic adverse effects. Okay, next.
Okay, next. A 77-year-old a 77-year-old man comes to the physician because of increasingly severe low back pain for 3 months. She has she has had poor control of bowel. She she has had poor control of bowel and bladder function for 2 weeks. He fell yesterday on his way to the bathroom. Mm, He has smoked 2 packs of cigarette daily for 60 years. Examination shows marked weakness of the lower extremity, normal upper extremity. Mm, Sorry. Examination shows marked weakness of the lower extremity and normal upper extremity strength, bilateral brisk dipton reflex of the lower extremity, and the sensory level is T9 and a flaccid anal sphincter. There is tenderness over the lower thoracic spine. Babinski sign is present. Which of the following is the most likely diagnosis?
Ready?
Ready?
Yeah.
Yes.
So it's epidural metastatic cancer. Epidural metastatic cancer resulting in spinal cord impingement. The most likely diagnosis in this patient with bowel and bladder incontinence, bilateral lower extremity weakness with hyperreflexia, and sensory level at T9 that has developed over the preceding 3 weeks. Vertebral masses may be the first presenting symptom of systemic malignancy, or they may be a late complication of metastatic disease. In either scenario, large mass can result in compression of the spinal cord at any segment with subsequent sensory and motor deficits below the affected segment. Sensory and motor. Okay. In this instance, the sensory level at T9 likely indicates the presence of a mass or at or just above T9 vertebral body in the epidural space. With compression of the spinal cord at that level, masses related to cancer must be distinguished from abscess or hematoma, as the treatment between the entities differ. Depending upon the type of cancer, steroids and radiation um, may, may be an initial option to reduce inflammation, with malignant compression of the spinal cord. In many cases, surgical decompression is required. It's not age. Transfer myelitis refers to an inflammatory syndrome involving particular spinal cord segment leading to weakness and sensory disturbance. Mm, okay.
Why it
Below
is
the
not
level.
TM?
Okay. It often follows an infection and symptoms reach maximum intensity within days, not weeks. We say, what is it? Not TM. What is TM?
Like transverse myelitis.
Oh, that's what I was reading. Refers to an inflammatory syndrome involving a particular spinal cord segment leading to weakness and sensory disturbance below the level of the lesion. It often follows an infection and symptoms reach maximum intensity within days, not weeks, and gradually improve.
I don't differentiate between these two, like epidural metastatic carcinoma and the transverse myelitis. It has, like, in transverse myelitis there is also sensory level. In transverse myelitis there is upper motor neuron lesion.
I think here is saying that the timeline here is months. Transverse myelitis will happen in, it says
Within weeks.
days, and within days. It will reach maximum intensity within days, not weeks. Here we're talking about months, so it's definitely past days. And then it should improve, and then it should be after an infection. Here, the key is that she's been smoking for I don't know how many years, 60 years. So it's probably some cancer. I think that was the key here.
Like long standing smoking, that's why it is like you figure out in that way. Long
Yeah,
standing smoking.
because I was also between that and transfer myelitis. But I don't know why, but I usually associate transfer myelitis with MS, and then MS is not going to
ms
happen in the
oh,
same.
ms has there are plenty of features of ms, and ms has one of the feature of transverse myelitis.
Yeah, but MS is never. It's not going to happen in the 77. What question have you seen MS in a 77-year-old woman man? Like MS is usually like a young girl. Like most, I feel like all the questions I see of MS is a girl and it's like a young um uh girl, like a productive age girl. Most of the questions. And then here they gave you the smoking, which is already a sign of like cancer. He's a man, and I mean there were a lot of clues that would point you more towards this than this. You know?
Okay.
I mean, I don't know. I know definitely I was left with between those two, but if once you're left between those two, you just have to find what guides me more towards this instead of this, and then that's where the smoking comes to the 77, the age, and the fact that he's a man. Uh, yeah,
Okay. Most of the time I miss like this kind of question, like epidural metastatic carcinoma.
I
Okay.
usually miss the transfer myelitis.
Okay. Both are quite similar.
Mm.
Okay, let's jump into next question. A 47-year-old man, a 47-year-old man is brought to the emergency department by his friend 30 minutes after being found unconscious in bed. The patient lives alone in a trailer park, and his friend says he was well the night before. The patient has no history of serious illness, takes no medication, he does not smoke cigarettes or use illicit drugs. He appears well malnourished. His temperature is 37 degrees Celsius, pulse 100 per minute, respiration 20 per minute. Blood pressure is 110 by 60. The nail beds and the oral mucus are pink. Neurological examination show meningismus. The pupil is 4 millimeter and sluggishly reactive. The doll's eye reflex, oculocephalic reflex is intact. There is no verbalization or eye opening in response to painful stimuli. He withdraws all his activity symmetrically to painful stimuli. Deep tender reflex 3 plus. Babinski sign is absent bilaterally. Routine Results of the studies are within normal. ABG show PCO2 is 30 and PO2 is 80 millimeter mercury, so acidosis. In addition to supportive care, which of the following is the appropriate therapy for this condition? Okay, but, this, uh,
Between methylene blue and physostigmine. Methylene blue was for what is it called? What is it called? Methemoglobinemia. Methemoglobinemia. It goes by I forgot what it was. Damn it. It's not physostig. Is it physostigmine? Physostigmine is for anticholinergic. Oh my god. Physostigmine is for cholinergic or anticholinergic. Uh, this does look like the signs of cholinergic or anticholinergic. Anyway, ready?
yes,
Oh, did it cut down? Okay,
yes,
okay. So it is barbaric oxygen, damn it. Carbon monoxide poisoning occurs as a consequence of inhaling the gas, often because of its generation in an area of poor ventilation, like garage door shut and car running, space heater in poor ventilating room, malfunction in basement and furnace. CO is a byproduct of combustion. When inhaled, it rapidly crosses the pulmonary capillary membrane and tightly binds to hemoglobin, inducing a conformation or change in the molecule and preventing the binding of oxygen. CO has an affinity for hemoglobin that's 100 times greater than oxygen, and it displaces oxygen from the heme. CO also has affinity for mitochondrial electron transport chain. Thus, in addition to hypoxemia resulting from interference with oxygen carrying capacity, cells may not be able to make use of the oxygen that they do receive via aerobic metabolism. The result, in aerobic metabolism dominates and lactic acidosis caused by hypoxia ensues. Symptoms of CO poison include headache, loss of consciousness, dizziness, vomiting, and fatigue. Severe cases, seizures, dysarrhythmia, coma, and death occur. Examination may show red skin. Treatment for CO poisoning begins with administration of 100% oxygen, regardless of pulse oximetry reading. And if any neurological symptoms or signs of end organ dysfunction are present, hyperbaric oxygen may be indicated. It is not methylene blue antidote for methemoglobinemia. It serves to reduce iron from methemoglobin F iron. It serves to reduce iron in Fe2 plus 2 plus, restoring his ability
He is in the
To line
park.
and transport oxygen. Methemoglobinemia may occur secondary to use of nitrate.
Trailer park.
Huh?
The patient lives in the
Let me see.
trailer park. Isn't a trailer park is an
Mm-hmm.
open space?
No, it can be close. It basically he lives in the car.
Oh, okay.
He lives in the windows of the car. Mm-hmm. Physostigmine is a reversible acetylcholinesterase inhibitor that is most commonly used in myasthenia gravis. May play a role in the treatment of anticholinergic toxicity as it can cross the blood-brain barrier. Anticholinergic toxicity is characterized by pupillary dilation, dry mouth, tachycardia, urinary retention. Okay, got it. Next.
Okay. A 5-year-old girl has the insidious onset of clumsy gait over the 3 months. Examination shows pace cavers of the left foot. There is generalized diminished girth of the left leg and decreased deep tendon reflex of the left ankle. The tendon reflexes are the tendon reflex at the knee are brisk. There is sacral tuft of hair. Which of the following is the most likely diagnosis?
Ready?
Yes,
With spinal cord. Where am I? Theta spinal cord affecting neural development, whereby caudal portion of the spinal cord becomes tethered to fixed fibrostructure that causes traction of the cord as the patient grows. The filum terminalis is a band of tissue that stretches between the caudal portion of the spinal cord and the sacrum, and persistent tethering of the spinal cord results in stretching as the child develops and axial growth occurs. Depending upon the severity, symptoms may present at infancy or can develop many years later, but progressive lower extremity dysfunction is typical as the spinal cord stretches and bends during normal activity. Sensory and gait normalities are typical, and bladder and bowel incontinence can occur. Low back pain that worsens with activity and pain in the perineum can also occur. Clues to diagnosis include of hair over the sacrum or the presence of hemangioma or dimples in the same region. Early detection of surgical intervention can improve symptoms and halt the progression of the neurological dysfunction. Frederick ataxia is caused by loss of function mutation in the frataxin gene that results from nucleotide repeat. Patients usually present in adolescence with progressive ataxia of all limbs and dysarthria. And distal sensory loss and dysphagia may also be present. Spastic dysplasia is a subtype of cerebral palsy and presents with symmetric spasticity of the lower extremities with associated sensory loss. Hmm. In rare cases, the upper extremity may be involved and intellectual disability will occur. Frederick ataxia is F A wait GAT GA
yes.
uh
Ataxic gait.
G yeah
GAA.
so it's GAT
GAA.
GAA for that. Okay, got it. Yep.
Okay, next. Okay.
Mm-hmm.
A 42-year-old woman with AIDS comes to the physician because of 2 week history of progressive right-sided weakness, large space, progressive right-sided weakness, large space, and headache. She is right-sided. Shows Fundoscopy examination shows papilla edema. Neurologic examination shows aphasia, right homonymous hemianopia, right-sided spastic weakness, aphasia, right homonymous hemianopia, and right-sided spastic weakness. CT scan of the head shows multiple small ring enhancing lesion with surrounding edema and a small effect on the left frontal, occipital, and parietal lobe. Which of the following is the most likely diagnosis?
Mm, the ring enhancing lesions. Hmm. Ready?
Yes.
Let's see. So is intracellular protozoan parasite transmission can occur through ingestion of oocyte from cat feces or infected meat, direct transmission between mother and fetus, or from organ transplant, which leads to infection followed by dissemination of the parasite where it typically lies dormant. It is ubiquitous organism. Nearly 10% of individuals will be seropositive for toxoplasma, but the parasite does not cause severe disease. Normal patients, in patients with HIV and CD4 count less than 100, the activation can occur and several distinct syndromes, of which toxoplasmosis result is the most, in which cerebral toxoplasmosis result is the most bad. Cerebral toxoplasmosis typically presents with multiple ring-enhancing lesions scattered to the brain. Seizures, focal neurologic deficits, and systemic symptoms are common, as are signs of increased intracranial pressure, hydrocephalus. Yeah. Patients with HIV and positive toxoplasma IgG antibodies are typically treated with empirically with sulfonamide and pyrimethamine if cerebral toxoplasmosis is suspected, but confirmatory diagnosis occur through brain biopsy, which will show dense infiltrated lymphocytes, macrophage, plasma cells, along with the toxoplasma on the organism. Cerebral toxoplasmosis is a age-defining disease. Now, cryptococcosis. It's caused by Cryptococcus neoform and encapsulated fungus and opportunistic pathogen in immunocompromised patients. It can cause cryptococcal meningitis, encephalitis, and pulmonary cryptococcosis. Meningoencephalitis presents subacutely with fever, headache, nuchal rigidity, and often accompanied by cough and shortness of breath caused by concurrent pulmonary infection. Focal neurologic deficit and mass lesion and neuroimaging are rare. It also has something on the brain, like the bubble lesions on the brain. Anyway,
Which one?
cysticercosis, the cryptococcus, it has something on the brain, like bubble something. You remember from Sketchy?
No,
Has some,
I don't remember actually.
um, it has something neoformans. You see, it has these subbubble lesions.
Okay.
Or was it me that maybe I'm okay? Like right here, it says at worst on imaging. Oh, it's
So
on
bubble.
imaging. Suburban lesion will be seized, suburban lesion on the mummy head, and fever. Archaeologist has the red face. Okay, I guess it's histology. I'm guessing this is how the suburban
Thi-
lesions do.
This is
I guess.
also a multiple ring enhancing lesion, isn't it?
Kind of looks like, let me look at the ring enhancing lesion of toxoplasma. Well, it didn't show the ring enhancing lesions, but it says it here. Ring enhanced scan will describe ring enhancing lesions. Thickly cut Gandhi glasses as extra lens rings. Okay, I guess that would be the ring enhancing lesions, these ones. But yeah, it doesn't show the how it will look on the imaging. So yeah. But I guess yeah, usually when they say ring enhancing lesions, it's usually toxoplasma. I've
So
seen probably on
sorry.
your word, usually when they say ring enhancing lesions is toxoplasma. When the only question I think in your word I've seen about like the bubble, they actually say bubble lesions for crypto. They one this one, and it was in I think it was your word, but it said bubble lesions. Like it didn't say ring enhancing lesions. So I guess they will specifically say, bubble lesions kind of thing. Anyway, cysticercosis tinea solium presents with headache, seizures, and increased intracranial pressure. Neuroimaging will show cystic ring-enhancing calcified lesions in the brain parenchyma, meninges, ventricles, spinal cord, and orbit. It less commonly presents with focal neurologic deficits such as doses in this patient. So here again is ring-enhancing lesions, cystic, oh, Jesus, but neurologic emonymous myopia, aphasia, and all these things that this person has, I guess. That's what they're saying. And it's not PML, the malignity disease of the CNS caused by polyoma and GC virus. Most commonly in compromise, it presents subacutely with altered mental status, ataxia, vision change, hemiparesis. Lesions occur primarily in the white matter that are not enhanced. Yeah, here there is no enhanced. They are hypodense. Okay. So it's between cysticercosis that we need to know and toxoplasma because
See,
cysticercosis also has lingering.
cysticercosis, there should be history of like taking a pig or pork, sorry, cow or
Yeah.
pork. Like tinea, there are two tinea, tinea saginata and tinea solium, isn't it? Tinea solium is for pig and saginata is for cow.
Mm-hmm.
So
But like toxoplasma also there is usually I guess yeah I guess okay I guess because usually there is an ingestion of some kind of
yes,
like well I guess yeah I guess well, AIDS is also yeah okay okay I get what you're saying.
next.
Mm.
A 52-year-old a 52-year-old man is brought to the emergency department because of 4-day history of progressive numbness and weakness of his legs. 6 years ago, he has had non-Hodgkin lymphoma treated successfully with chemotherapy and radiation therapy. He is currently taking no medication. Cranial nerve examination shows no abnormality. Muscle strength is intact in the upper extremity. Muscle strength is intact in the upper extremity 3 by 5 and in the proximal lower extremities 4 by 5 in the distal lower extremities. Deep tendon reflexor 2 plus in the upper extremity 3 plus. Deep tendon reflexor 2 plus in the upper extremity 3 plus in the lower extremity. Babinski sign is present bilaterally. Um, Sensation to pinprick is decreased below the level of the nipple, and to the vibration sensation is decreased over the feet or ankles. Which of the following is the most likely diagnosis? The pinprick is decreased below the level of the sensation below the vibration dorsal column is sensation pinprick is fine touch process. Mm, GPS is not allowable. Adjustable cord compression. Power to intact. Oh, my bad. Having 70 press. Not cord. Ready?
Yeah. Is metastatic spinal cord compression. Metastatic spinal cord compression occurs most commonly in prostate, lung, and breast cancer, although it can occur with any malignancy. It is generally caused by vertebral bony metastases that tend to occur in the vertebral body, particularly of the thoracic spine. It is This presentation depends on the level of the lesion and degree of spinal cord compression. Symptoms include back pain, which is often worse at night or while laying down, muscle weakness, sensory abnormalities, bladder and bowel dysfunction, and gait instability. It will generally present with an open motor neuron pattern of injury in the lower extremities, with hyperreflexia and positive Babinski sign, as in this patient, assuming the compression is in the thoracic or upper lumbar region. Ascending numbness or paresthesia are also common. Diagnosis is clinically made utilizing MRI of the spine. Patients may be treated with steroids, radiation therapy, and surgical decompression and spine stabilization. It's not chemo-induced polyneuropathy classically presents with sensory loss um, and paresthesias in the distal extremities that ascend in a stocking and gulf pattern. Most chemo-induced polyneuropathy will improve over time after chemo is stopped, making it less likely explanation for this patient acute onset of symptoms. And it's not paraneoplastic neuropathy is an immune-mediated destruction of neuronal tissue in the presence of an underlying malignancy. It can present in a variety of ways, such as acute sensory radiculopathy, acute sensorimotor radiculopathy, chronic sensorimotor neuropathy, or autonomic neuropathy. These patient symptoms will be more similar to an acute sensorimotor radiculopathy, but this symptom presents with a predominant ascending motor paralysis. Okay.
So why it is spinal cord compression?
Because he had cancer and the cancer metastasized. And they're saying that spinal cord compression will show with upper motor neuron signs in the lower extremity.
Promoter. Okay. Cord compression. A previously healthy 62-year-old man 62-year-old man had a progressive difficulty with speech and swallowing over the past year. Symptoms were subtle at first, and only he and his family is noted with the problem. Recently, two ham radio colleagues have commented that he sounds different on the air. He has also noticed that he has difficulty in manipulating object in the left hand and walking smoothly and going up and down stairs. He has not had any difficulty with his thought process. Examination shows delivered speech, mild dysarthria, cranial nerves are otherwise normal. There is wasting in the intrinsic hand muscle and distal weakness in the left hand. Gait is slow, slightly broad-based, but Romberg sign is absent. Gait is slightly broad-based, but Romberg sign is absent. Deep tendon reflex are 3 plus in the left upper extremity, 2 plus in the lower extremity. Right upper extremity 3 plus, in the lower extremity jaw jerk is hyperactive. His serum potassium is 3.2, and X-ray of the chest shows normal finding. Which of the following is the most likely diagnosis? Uh, what is your diagnosis? There is upper motor neuron sign and lower motor neuron sign. There is wasting. Cranial nerves are normal.
Between MS, myasthenia gravis. Towards at the end of the day, process and muscle weakness. No, I'm between ALS and MS, but ALS doesn't happen. I mean, sorry, MS doesn't happen. It's not usually both men with. I'll go with ALS. Ready?
Yes.
Okay.
Oh,
So the answer is ALS. ALS is likely given insidious. Is likely given insidious onset of upper and lower motor neuron. Oh, that's why I was forgetting. ALS is upper and lower. Okay. ALS is caused by progressive destruction of motor neurons. Patients may develop asymmetric weakness of the extremities, unilateral hand weakness, foot drop, and bulbar symptoms like dysphagia, voice changing may occur simultaneously. On physical exam, the presence of both upper motor neuron signs such as hyperreflexion spasticity, combined with lower motor neuron signs such as hyporeflexia, suggests the diagnosis. Parkinson features such as mass faces, tremors, shifting gait may occur as can autonomic dysfunction. Eventually, patients develop respiratory insufficiency. The clinical progression is results in death. It's not M. What is M? Multiple sclerosis is the malignant disease affecting white matter in the brain and spinal cord. This can lead to weakness, hyperreflexion, spasticity. Optic neuritis is classic presenting symptom. Okay, next.
yes.
Okay.
A 27-year-old boy is admitted. 27-year-old boy is admitted to the hospital because of 4-week history of difficulty with speech. 4-week history of difficulty with speech and weakness of the right leg. He has a 5-year history of HIV infection treated with antiretroviral therapy. On admission, her temperature is 37 degrees Celsius. Examination shows thrush. Examination shows thrush. There is mild non-fluent aphasia. Physic. There is mild non-fluent aphasia. Muscle strength is 4 by 5 in the right lower extremity. Muscle strength 4 by 5 in the right lower extremity. Deep tendon reflex is 3 plus, and lower extremity is 3 plus in the right lower extremity and 2 plus in the other. Was Babinski sign is present on the right, and MRI of the brain shows 6 ring enhancing lesion on the cerebral hemisphere bilaterally. The largest lesion in the frontal lobe. Some of the lesions have surrounding edema. In some of the lesions and pyrimethamine sulfadiazine is started. 2 weeks later, there is no improvement of the symptom. MRI of the brain show no decrease in the size of the lesion, and some have increased in size. Which of the following is most likely diagnosis?
Hmm. Ready?
Yes,
Okay. So it is CNS lymphoma. CNS lymphoma is a rare variant of non-Hodgkin lymphoma that occurs most commonly in immunocompromised patients. It can occur in the brain, spinal cord, meninges, or eye. Presenting symptoms include focal neurologic deficits, vision changes, neuropsych symptoms, and signs of increased intracranial pressure like headache, nausea, emesis. Okay. In immunocompetent patients, neuroimaging will most commonly show a solitary hypodense periventricular mass with well-defined borders and mass surrounding edema. In immunocompromised patients, however, the development of primary CNS lymphoma is strongly associated with um, EBV infection, with additional risk factor in HIV, including a decreased CD4 T lymphocyte count, and increased viral load, and chronic infection with Hep B and Hep C virus. Imaging of immunocompromised patients more commonly shows multifocal disease, numerous ring or heterogeneously enhancing lesions to the corpus callosum, periventricular areas, and periependymal regions. The diagnosis is confirmed by biopsy and CSF flow cytometry or cytology with evidence of EBV DNA or in the CNS supporting the diagnosis. Treatment typically consists of high dose, generally intrathecal chemo and antiretroviral therapy. It is not CDNE. Cryptococcal meningitis presents subacutely with fever, headache, nuchal rigidity, um, yeah, and photophobia, as well as encephalopathy in severe cases. Most commonly in immunocompromised patients, neuroimaging typically shows no abnormality, and the diagnosis is made with serum cryptococcal antigen. Listeria occurs in patients at the extreme of age, older or neonate. And in those that are immunocompromised, it classically present with fever, headache, nuchal rigidity, antemental cranial nerve palsy, and focal neurologic deficit. While listeria can cause brain abscesses, this is rare. Nocardial abscesses can occur in immunocompromised patients. They classically present with fever, headache, signs of meningeal irritation, and focal neurologic deficit. It more commonly occurs in a concurrent pulmonary infection, which is associated with fever, wail of cough, moptisis, shortness of breath, and chest pain. Okay,
okay.
next.
A 67-year-old woman comes for a routine health maintenance examination. She is concerned about developing dementia. She lives alone. She does not want to be burden to her children. Her father was just diagnosed with dementia, Alzheimer type. She has no medication other than hydrochlorothiazide for hypertension. Her blood pressure is 124/84. Examination shows no abnormalities. Which of the following measure is likely to decrease her risk of multi-infarct dementia?
Ready?
Yes.
Discontinued control of BP. Vascular dementia is the second most common form of dementia after Alzheimer, characterized by stepwise cognitive decline following recurrent strokes. The rate of decline and specific symptoms depend on the regions of the brain affected. Patients typically develop cognitive impairment, motor dysfunction, um, behavioral changes as the disease progresses. These factors include age, hypertension, obesity, diabetes, hyperlipidemia, prior strokes. Diagnosis is made clinically with support of neuroimaging demonstrating um, cerebral ischemic changes. Risk factor reduction is the primary approach to prevention. Continued control of BP is most likely to decrease the risk of this patient developing vascular dementia. Next.
A previously healthy 45-year-old woman is brought to the emergency department 1 hour after she lost consciousness while shopping in a departmental store. On regaining consciousness, she has a severe headache and photophobia. Her temperature is 37 degrees Celsius, pulse is 110 per minute, respiration 14 per minute, blood pressure under 10 by 70. Examination show slight neck stiffness with flexion. There is pain with lateral deviation of the eyes. Neurologic examination showed no abnormality. CT scan of the head showed no lesion and evidence of bleeding. Which of the following is the most appropriate next step in the management? Pain, lateral deviation.
I have no idea. What if she has meningitis?
But why pain on the lateral deviation of eye?
Yeah, don't make that much sense. So just admit for observation.
But
Mm. She meningitis. She don't have no fever. She don't have no mental status. I don't know.
she has a
Ready?
severe headache and photophobia. I think that MRI should be done.
Oh, ready?
Okay.
Subarachnoid puncture. Subarachnoid hemorrhage refers to bleeding into the subarachnoid space and can be caused by aneurysm. Oh, it's an aneurysm tap up or non-aneurysmal rupture of an artery in the subarachnoid space. Patients typically present with acute severe headache, often described as worst headache of their life, along with neck stiffness, photophobia, possible stupor, and coma. Fever can be associated with subarachnoid as is associated with worse outcomes. CT scan of the head typically shows hyperdense blood products in the cerebral sulcine system, basal systems. However, the sensitivity of CT scan for subarachnoid is lower with small volume bleed or delayed presentation. If there is strong suspicion of subarachnoid hemorrhage with a negative CT scan, lumbar puncture can be performed, which can show red blood cells and xanthochromia, which represents hemoglobin degradation products. As the blood products circulate within the subarachnoid space, complications include the development of communicating or obstructive hydrocephalus in the acute stage, along with potential for a bleeding and vasospasm in the days following the initial bleeding. It is a neurosurgical emergency that may be fatal if progressive. It's not that admission for observation will not be indicated until further workup is performed to evaluate for subarachnoid hemorrhage. First, a subarachnoid hemorrhage should be investigated by lumbar puncture, and if findings are consistent, vessel imaging should occur to evaluate for aneurysm or heavy malformation. And you said you wanted MRI of the brain would be indicated for evaluation of ischemic stroke or tumor. The patient does not display any focal neurologic symptoms or aphasia to suggest ischemic stroke. Tumors can also cause headache, but typically chronic or subacute headache and associated with vomiting and papilledema. Okay, next.
A 72-year-old woman is brought to the emergency department 6 hours after the onset of double vision, loss of balance, dizziness. She has no history of similar symptoms. She sustained a myocardial infarction 2 months ago. She has hypertension, type 2 diabetes mellitus. Current medication include insulin and clonidine. She appears anxious. Her temperature is 37.1, pulse is 100 per minute, respiration 18 per minute, blood pressure 160 by 90, blood pressure 160 by 90 millimeter mercury in both arms. A left carotid bruise, her pulses are decreased on the lower extremity. Pulses are decreased of the lower extremity. Atherosclerotic involvement of which of the following artery is most likely the cause of patient symptoms?
Ready?
Yes.
It's vertebral artery. This patient likely has occlusion of the vertebral artery leading to vertebrobasilar insufficiency. Vertebrobasilar insufficiency can be caused by ischemia in patients with poor sympathetic regulation or thromboembolism commonly originating from an atherosclerotic plaque in or dissection of vertebral artery, known as posterior circulation stroke. This factor for posterior circulation stroke includes smoking, hypertension, age, hyperlipidemia, coronary artery disease, and peripheral artery disease, as evidenced by patients' diminished lower extremity pulse. The brainstem, cerebellum, and occipital lobes are commonly affected. Patients typically present with vestibulocerebellar signs, ataxia, dysmetria, dizziness, imbalance, vertigo, vomiting, nystagmus. Ipsilateral cranial nerve dysfunction as dysphagia, dysarthria, um, gaze palsies. Contralateral hemiparesis caused by corticospinal tract damage, and contralateral impairment in pain and temperature sensation caused by spinothalamic tract damage, and or contralateral homonymous hemianopia with macular sparing caused by posterior cerebral artery involvement. Unlike hemispheric stroke arising from internal carotid arteries, cortical deficits such as cognitive and speech impairment are typically absent. A non-constant CT scan of the head rules out hemorrhage, and the diagnosis may be confirmed with facial imaging if the lesion is sufficiently large. If no hemorrhage is seen, acute management of posterior circulation strokes may involve tissue TPA therapy or thrombectomy. It is not common. Carotid artery occlusion from atherosclerotic disease less frequently causes symptoms because of retrograde collateral flow through the external carotid artery. If a stroke were to occur, it would affect the ipsilateral anterior and middle cerebral artery territory, which will not result in signs of vertebrobasilar insufficiency. Internal carotid artery supplies the MCA, which supplies the lateral and frontal and anterolateral parietal lobes. During acute occlusion of the internal carotid, typically seen as thrombus, or MCA artery, patients may present with hemiparesis, hemisensory deficit, along with speech impairment. Hmm. What are the vertebrobasilar symptoms that they're talking about?
Vertebrovascular symptoms are like dysphagia, dysarthria, dysphonia, all the D symptoms, and the drop attack. These are the features of vertebrovascular insufficiency.
Mm,
You got my point. If we
okay.
find those type of feature like dysphagia, dizziness, dysarthria, diplopia, um, dysarthria, dysphagia, and there may be nausea, vomiting also. If we found this kind of feature that indicates vertebrovascular insufficiency. And your question, you are talking about the symptoms, isn't it?
Mm-hmm. Mm-hmm. I got, yeah. Yeah.
Okay,
Mm. Okay. Next.
okay. A 37-year-old woman with alcoholism is a 37-year-old woman with alcoholism. Or a 37-year-old woman with alcoholism is hospitalized for detoxification. On the second day after admission, she has an impaired sensorium and a decreased attention span. During examination, she appears frightened and disoriented and shrieks, "Make the snakes go away." Her temperature is 101 degree Fahrenheit, pulse is 110 per minute, blood pressure 190 by 120 millimeter of mercury. Which of the following is the most appropriate next step in the management?
Mm, don't know. This one. Where is my pen? Ready?
Yes.
Okay. So it is oral prodiazepoxide therapy. This patient has development of delirium tremens. A serious complication alcohol withdrawal alcohol increases the CNS activity of GABA, the main inhibitory neurotransmitter. Abrupt discontinuation of alcohol results in imbalance and unopposed sympathetic excess. Uncomplicated alcohol withdrawal typically presents with tremors, anxiety, restlessness, headache, nausea, diaphoresis, which can begin hours after the cessation of alcohol use. Delirium tremens, the most concerning and life-threatening complication of alcohol withdrawal, and involves severe confusion and disorientation, fluctuations in consciousness, agitation, visual hallucinations, autonomic instability, tachycardia, hypertension, whatever, hyperthermia. As in this patient, delirium tremors can begin like 2 to 5 days after the patient last alcoholic. Delirium tremors managed by benzos to address the psychomotor agitation associated with the withdrawal and prevent whatever. The specific benzo used are chlordiazepam. Oh, I forgot it was a benzo. A long-acting benzo, whatever, given on a scheduled basis in patients, and lorazepam and short antibenzo. Management also includes frequent assessment, including vital check-ins, free resuscitation, nutritional supplement, especially with vitamins like thiamine, potassium, magnesium, whatever. It's not intravenous, it's not theoridazine, a first generation antipsychotic, will be a necessary. Okay, that's a first generation antipsychotic. Okay. It's not IV thiamine, should be administered during the patient's hospitalization to prevent Wernicke whatever. However, IV thiamine does not emergently address alcohol withdrawal symptoms such as this patient autonomic dysfunction.
Okay. And otherwise healthy 42. An otherwise healthy 52-year-old woman is brought to the emergency department 3 hours after sudden onset of severe low back pain and severe shooting pain down her buttock and leg. The pain began when she arose quickly from a seated position to open a sliding glass door. Two analgesic tablets left over from a dental procedure provided no relief. She is an avid cyclist. On arrival, IV administration of the morphine is begun, provided minimal relief. The patient notes numbness over the perineum. Patient notes numbness over the perineum when she attempts to void. She is reluctant to move from a flexed seated position to stretcher because of pain. Muscle strength is 3 by 5 on grade 2 extension, dorsiflexion and plantar flexion of the left foot. Knee jerk is presented on the left. Achilles tendon reflex is absent on the left. Achilles tendon reflex is absent on the left. An MRI of the lumbosacral joint show large central herniation of the lumbar form 5 that compresses L5 and S1 nerve on the left. Which of the following is the most appropriate next step in the management? Large central.
I'm thinking they mean like this herniation. I'm thinking that's what they mean.
Yes,
Ready?
yes.
Okay, so it's lumbar laminectomy. Cardiac syndrome occurs as a result of compression of spinal nerve root comprising the cardia equina. Often such compression occurs because of malignancy, trauma, compression fracture, whatever. This herniation, spinal stenosis, spinal epidural abscess, spinal whatever hematoma. Symptoms include lower extremity numbness, weakness, paralysis, hypoexia, perineal anesthesia, fecal incontinence with poor rectal tone, and overflow incontinence marked by inability to void and urinary retention. Emergent MRI of the lumbosacral spine is indicated to investigate the cause of quadricular syndrome and to determine the necessity of surgical decompression. Initial treatment for patients with epidural spinal cord compression and neurologic deficits includes symptomatic treatment, pain control, steroid therapy, prior to operative therapy. High dose steroid therapy is helpful as a bridge to definitive therapy and can control pain and may transiently improve neurologic function, secondary to decreasing the edema. However, cardiac echinacea is a surgical emergency and requires decompression with lumbar laminectomy as soon as possible. It's not physical therapy can be used in the management of other types of back pain such as lumbosacral strain. However, lumbosacral strain will not cause perineal anesthesia and neuromuscular weakness. Cardiac equina is a surgical emergency, making physical therapy incorrect. Next.
Next. A 32-year-old man comes to the physician 2 hours after the onset of dizziness, nausea, and unsteadiness. He had a whiplash neck injury 2 years ago and is still recovering monthly uh, chiropractic manipulation. His voice, sorry, is still receiving. Okay, his voice is hoarse. There is ptosis and nystagmus. The left pupil is 2 millimeters smaller than the right. Left. Okay, left ptosis, left nystagmus. There is decreased sensation to the pain on the left side of the face and the right extremity. He has no ataxia. M- Mental status examination shows no abnormality. Which of the following arteries is most likely to be occluded? Really?
Mm-mm.
Is it LMS?
I don't know what you mean by LMS.
Lateral medullary syndrome.
Oh, I don't know. Let me
What is your
see.
differential?
I'm between. Actually, I'm just between the middle cerebral artery. Middle cerebral. Like yeah, the middle cerebral. I'm trying to figure if it's the left or the right. Um,
Okay,
left ptosis, left ptosis. I'll just go with the left. Okay. Let's see. Oh, you said already. So it's left vertebral. At least I know it was left. This patient likely has occlusion of the left vertebral artery leading to vertebrobasilar insufficiency. This vertebrobasilar thing. Vertebrobasilar insufficiency can be caused by ischemia in patients with poor sympathetic regulation or thromboembolism, commonly originating from atherosclerotic plaque in or dissection of um, in or dissection of the vertebral artery known as posterior circulating stroke. A thrombus of the vertebral artery commonly forms from atherosclerotic disease, but may also form as a result of intimal defect from trauma, blah, blah, blah. Also known as chiropactic manipulation. The brainstem, cerebellum, and occipital lobes are commonly affected. Patients typically present with symptoms I guess, of the cerebellar, which is ataxia, dysmetria, dizziness, balance, vertigo, vomiting, blah, blah, blah. Symptoms of she said, the brain stem, that would be the cranial nerve dysfunction, like dysphagia, dysarthria, vertical and horizontal gain spasms, and symptoms of the contralateral hemiparesis, contralateral spinal cord damage, contralateral impairment in pain and temperature sensation caused by spinothalamic damage, and contralateral eponymous hemianopia with macular spreading caused by the occipital lobe, whatever, posterior cerebral artery involvement. In posterior circulation strokes affecting the lateral bones, Horner syndrome may occur, which presents with unilateral ptosis, meiosis, and ipsilateral facial anagnosis. If hemorrhage is shown on CT scan of the head, acute management of posterior circulatory infarct may involve tissue plus TPA and thrombectomy. In dissection, antiplatelet and anticoagulant administration is indicated to prevent conversion of thromboembolic stroke to a thromboembolic stroke if none yet has occurred. It is not where is right here. Left and right internal carotid artery supply the left and right anterior and middle cerebral arteries, MCAs. MCA supply the lateral frontal lobe and anterior parietal lobe and temporal lobe. Occlusion of the ICA or MCA leads to contralateral hemiparesis and contralateral sensory deficit of the face and upper extremities. Okay.
okay.
Mhm.
Vertebrovascular insufficiency. There are two questions. I don't get it. How it can be diagnosed. Okay, a 37-year-old woman comes to the physician because of 4-month history of headache and blurred vision. He has no history of serious illness, takes no medication, mains occur at irregular 2 to 10 weeks interval. She has 18 kg weight gain and during the past 7 months. She is 18 kg weight gain during the past 7 months. She is 163 centimeter tall, now weighs 86 kg, BMI is 33 kg per meter. Vital signs. Visual activity is 20 by 20. Visual field testing show no abnormal CV examination show blurred optic disc. There is no spontaneous venous. There are no spontaneous venous pulsation. The remainder of the examination show no abnormality. CT scan of the head shows small left ventricle. On lumbar puncture, their opening pressure is 290 millimeter of mercury. CSF analysis should know leukocytosis and lymphocyte. Which of the following is the most likely mechanism of this finding? Okay,
Sorry, I wasn't even reading with you. One moment. My so I shall update this. Most continuous venous pulsation, blah blah. Small lateral ventricles. Open impression shows no leukocytes and no erythrocytes. Mechanism of these findings: headache and blurred visions. So high intracranial pressure. From she's young and she's fat. Mm, okay. It's impaired reabsorption of CSF. Impaired absorption of CSF is the primary mechanism behind pseudotumor cerebral or idiopathic intracranial hypertension. Uh, IIH is characterized by signs of increased intracranial pressure, including headache, papilledema, increased opening pressure on lumbar puncture without any underlying pathology to cause such finding on imaging. It is primarily seen in young women who are overweight, although there is no malignant cause underlying the increase in intracranial. It may cause debilitating headache, permanent vision loss, headaches that are secondary to increased intracranial pressure often are worse when lying down and relieved by standing. The most common risk factors for development of pseudomotor cerebral include female and obesity. However, vitaminosis A from increased dietary intake is another potential cause. This can be from excessive dietary intake or from use of retinoid medications such as isotretinoin or retinoic acid. Other medications associated with eye include tetracycline, danazol, and growth hormone. Next.
okay. A 6-year-old boy is brought to the emergency department 20 minutes after a motor vehicle collision in which he was the unrestrained front seat passenger. He lost consciousness momentarily. Examination showed 2 by 2 centimeter area of the soft tissue dwelling over the head, a small abrasion on the left cheek, and a abrasion on the right elbow. Neurologic examinations are normal. Which of the following is the most likely diagnosis? Oh,
Okay.
Yes.
So, a cerebral concussion, mild traumatic brain injury, also known as concussion, commonly result in the loss of consciousness, confusion, amnesia, headache, dizziness, nausea, vomiting minutes after the injury. Concussion can be caused by direct or indirect blunt head trauma and typically causes self-limited brief neurologic impairment such as the loss of consciousness, repetitive questioning, confusion. Symptoms that commonly develop within the following days include mood disturbance, photophonophobia, trouble concentrating, and insomnia. Patients do not have focal neurologic symptoms such as limb weakness or vision changes that will indicate traumatic vascular injury or intracranial hemorrhage. Um, All patients with suspected concussion should undergo a thorough neurologic exam, and subset of at-risk patients should receive neuroimaging. All patients should be monitored closely for neurologic deterioration, which may indicate developing intracranial hematoma to prevent more cumulative brain injury. For my second conclusion, patients with concussions should return to their usual activities in a graded fashion, beginning with the return to school and without return to sports until cleared by the physician. It's not closed head injury. Refers to blunt head trauma with no object penetrating the skull and dura mater. Blunt head trauma with no object penetrating the skull or dura mater and encompasses a variety of injuries such as hematoma, skull fractures, cranial hemorrhage, traumatic brain injury. This patient lost consciousness momentarily and has no other apparent neurologic deficit, making concussion more specific diagnosis. It is not a epidural. Classically occurs after injury to the middle meningeal artery and can present with an initial lucid interval followed by deterioration of mental status as a result of bleeding and hematoma. Epidural hematoma presents on CT scan, so they would have seen it on CT scan. That's what it says. And,
Next.
and it's not
Sorry.
facial bone. Oh, sorry. It's not facial bone fracture can occur as a result of direct blunt trauma to the face and can be associated with pain and ecchymosis. Patient can present with a variety of symptoms and depending on the facial bone that is fractured, including facial deformity, mid-face instability, malocclusion. Yeah, it's not frontal skull fracture. It's uncommon as a result of hardness of the bone but can occur after severe high impact blunt head injury and can be associated with intracranial bleeding. It can present with swelling, tenderness, and palpable skull defect or crepitus. Okay, next.
Okay.
Next. Mhm.
A previously healthy 6-month-old girl is brought to the emergency department by ambulance because of difficulty breathing. Her mother says that she fell from the couch to a carpeted floor yesterday. She cried immediately and was fine until several hours later when she could not be aroused and seemed to gasping for breath. Her mother noticed some emesis in the bed. On arrival, she is lethargic, temperature normal, pulse 130, respiration 36, blood pressure 90/60. Examination show bulging anterofrontally. There is bilateral retinal hemorrhage, nebulizer examination. Um, no abnormality. CT scan of the head show blood along the fork. Which of the following is most likely diagnosis? Ready?
No. Mm, orbital blow. Shaken baby syndrome. Subdural. Skull fracture. Pyramidal meningeal. Mm, 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 mm.
Ready?
Yes. Mm, 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 mm. So is shaken baby syndrome no? Severe intracranial injury with a history inconsistent with the severity of the patient's physical finding, raises suspicion for abusive head trauma and non-accidental trauma. Patient with abusive head trauma can present with encephalopathy, apnea, seizures, and retinal hemorrhage. The mechanism hmm, of abusive head trauma is typically blunt force of shaking, which results in acceleration deceleration force on the infant. Infants are vulnerable to deceleration injury because of several factors. The large head and weak neck musculature result in greater movement of the brain in the intracranial space when acted upon acceleration valve. In addition, the infant skull is thin, allowing forces to transfer to the skull to the brain. Finding of CT scan associated with an accident includes subdural hemorrhage, especially multiple hemorrhage or those in an interhemispheric or posterior focal location, hypoxic ischemic injury, and cerebral edema. It is not J. Where is J? It's not J. Intracerebral hematoma can occur secondary to trauma, aneurysm, IV malformation, tumor, hypertension. It would appear on CT scan as area of intraparenchymal hyperdensity, whereas interhemispheric hemorrhage is more specific for uh, shaking baby syndrome. Okay.
Next.
Mhm.
A 67-year-old woman comes to the physician because of 7-month history of progressive bilateral pain. She describes bilateral back, posterior thigh, and calf pain that begins after standing or walking for 10 minutes. It is relieved 2 minutes by bending forward at the waist. She has a coronary artery disease, underwent CABG for 2 years ago. Neurological examination show no abnormal. Which of the following is the most appropriate? Next.
Mhm. Mm, between
Is it spinal
diaphragmatic.
stenosis?
It sounds like it. So I'm between nerve conduction studies or MRI. I know spinal stenosis, spinal stenosis. I guess it would be MRI. I don't know. Ready?
Yes.
Okay. So it's MRI. This patient presenting with symptoms of spinal stenosis with neurogenic claudication. Spinal stenosis describe narrowing of the central canal, neural foramen or lateral recesses of the spine with subsequent nerve compression and ischemia. Common causes include degenerative arthritis, spondyloarthropathy, degenerative disc disease, hypertrophy of the ligament of fiber, osteophyte formation in the facet joints. Neurogenic claudication describes low back pain with radiation to the buttocks and lower extremity that result from increased nerve compression and may occur with extension of the spine during standing or walking downhill, reducing narrowing reducing narrowing within the spinal column with spinal flexion as during sitting or walking uphill test to relieve the pain. Diagnostic evaluation involves X-ray imaging followed by MRI of the lumbar spine. It's not electromyograph or nerve conduction study can be used to confirm the presence of radiculopathy caused by nerve root compression or evaluate for other myopathy or neuropathy as these tests are reasonable if the diagnosis is still in doubt after initial imaging study. Okay, next.
Next, a 37-year-old woman has had throbbing right-sided headache that began gradually 6 weeks ago. It is increased in frequency and severity. The headache typically begin in the morning shortly after arising and last up to 1 hour and several times a day. Occurs several times a day. Acetaminophen provided partial relief, and it is irritable and has been unable to keep up with daily activities. Which of the she appears upset. Lab examination show a persistent attention deficit and left arm drift. Pronotum drift. Neurological persistent attention deficit and a left arm drift. Which of the following is the most likely diagnosis?
Hmm, don't know. Ready?
Yes.
Okay, so it is brain tumor. This patient examination findings of attention deficit, likely neglect, and left arm drift are suggestive of the presence of a contralateral upper motor neuron lesion, which in conjunction with her symptom of new chronic headache is suggestive of brain tumor. Hemispatial neglect often occurs as a result of lesions of the parietal cortex and may also occur in stroke. Similarly, left arm drape may suggestive of upper motor neuron lesion in a variety of locations such as contralateral frontal cortex, cerebellum, pyramidal tract. Collectively, these patients finding localized lesion to the right parietal cortex. Okay, next.
Next. A 57-year-old woman comes to the physician because of 3 year history of increasingly severe pain, swelling, and numbness of her left arm and shoulder. During the past 8 weeks, she has had difficulty moving her left arm because of these symptoms. 15 years ago, she underwent left radial mastectomy and followed by radiation therapy of the chest wall for breast cancer. There has been no evidence of recurrent breast cancer. She has hypertension treated with atenolol. Her only other medication is ibuprofen as needed. Her temperature is 37 degrees Celsius, pulse is 78 per minute, respiration 60 per minute, and there is 2 plus pitting edema of the entire left upper extremity. Examination of the right upper extremity show abnormalities. Radial and ulnar pulses are 2 plus equal bilaterally sensation pinprick and motor function of the left upper extremity are absent. Photograph shows chest wall and left upper extremity is shown. An MRI of the brain of the left upper extremity and shoulder show fibrosis of the masses. Which of the following is the most likely symptoms? So it
Ready?
ca- so it is it complex regional pain syndrome, or is it
Oh,
sorry,
oh no, I don't know the diagnosis here. I don't know what she's having.
uh,
B and C, but I don't even know what she's having.
okay.
So it is radiation-induced brachial plexopathy. Oh, that's a good guess. Radiation-induced brachial plexopathy is a potential complication of radiation to the brachial plexus, most commonly occurring after radiation therapy for breast or lung cancer. Radiation damages the brachial plexus and presents with symptoms of brachial neuritis, including pain, paresthesia, and weakness in the distribution of the affected nerve may occur months to years after the initial insult. In this scenario, the radiation has likely affected C5, C6 nerve roots called air palsy, leading to difficulty of the deltoid, supraspinatus, infraspinatus, and biceps brachial muscle, resulting in impaired upper extremity abduction, lateral rotation, flexion, and supination. Consequently, the patient's upper extremity hangs near the body in a medially rotated, extended, and pronated position as shown in the yeah. Lymphedema of the upper extremity can also result from radiation-induced fibrosis of the lymph nodes. It is often associated with radiation-induced brachial plexopathy. Neoplastic brachial plexopathy should be ruled out with MRI. Treatment is supportive and includes brachial decompression, surgery, pain management, and physical and occupational therapy. It's not C, reflex sympathetic dystrophy or complex regional plex syndrome. That's the other name. Reflex sympathetic dystrophy presents with regional pain that is out of proportion to the insult. Patients may also experience edema, abnormal sensory or motor findings in the region. This patient instead possesses a pattern of findings like Erb's palsy and lymphedema, consistent with radiation-induced brachial plexopathy, indicating her symptoms are not out of proportion to the insult. Okay.
Okay. Last one is ethics. An 82-year-old woman, sorry, 82-year-old man is brought to the emergency department 1 hour after he collapsed while walking in his garden. He has hypercholesterolemia. He has smoked 2 packs of cigarette daily for 6 years. His temperature is 37 degrees Celsius. Uh, pulse is 96 per minute, and irregular respiration 18 per minute. Blood pressure 150 by 90. He is awake but unable to speak to facial or tongue paralysis. He is able to blink his eyes and move his eyes vertically on command. He cannot move his eyes. Examination shows complete paralysis of the all extremity. Sensation to touch is intact. He undergoes endotracheal intubation for air protection. IV hydration is begun. MRI of the brain show extensive infarction of the base of the palm. So due to basilar artery occlusion, conservative management is recommended. Although he cannot speak, he can communicate clearly by means of the code using eye blinks. The patient clearly communicates to his physician repeatedly that he wants no life support or artificial hydration and wants to die because of poor prognosis for recovery. His wife and 2 sons agree with the decision, but an estranged daughter does not and is threatened for legal action. Which of the following is the most appropriate?
Next. Sorry. Ready?
Yes.
So it's E. Patient should be made DNR and intubated and fluid should be withdrawn as he wishes. Neurologic impairment patients should not be assumed to lack decision capacity to make decisions about their care. The medical team should evaluate the decisional capacity of this patient who's making decision about his end of life care. This patient is able to communicate a consistent decision and demonstrate an appreciation of consequences in his decision. Therefore, he appears to possess decisional capacity to make decisions to withdraw care. The medical team should respect the patient's autonomy and withdraw care. If a patient lacks decisional capacity, the medical team should identify surrogate decision maker unless the patient has identified a durable power of attorney. The spouse should serve as a decision maker. Adult children are typically second line, followed by parents. Further reassuring in this case is that the patient wife and adult children corroborate his decision. His extended daughter wishes may not affect the patient wish, and given demonstrated decision not upon. Yeah, done.
Okay. Let's